Hi, this is Mrs. Hauk. This podcast is about pulmonary embolism, which is a cause of obstructive shock. A pulmonary embolism can be partial or complete obstruction of the pulmonary vasculature. Mortality is about 10 to 50%, but can rise to as high as 60% in those with shock. Now, when we talk about pulmonary embolism, we talk about it in a general term, but you need to know that they exist on a spectrum. Anything from small peripheral clots to a submassive PE to a massive PE, both of which the submassive and massive can turn into shock. Also, you may not have some of the exact slides that are in this podcast because I did in your packet because I did update this PowerPoint. Basically, a collection of particulate matter that enters into venous circulation and lodges in the pulmonary capillary bed, blocking blood flow. So that's how it is an obstructive form of shock. It blocks the blood flow. It can be a clot, but it could be other material. It could be fat from a long bone fracture. It could be air introduced by a central line or central line insertion, and amniotic fluid from postpartum, or sepsis, because sepsis can create septic particulate matter type emboli. Blood clot is the most common. 80% of pulmonary embolisms originate as a deep vein thrombosis, which I believe you learned about in 150 or 151. Basically just some pictures that show you the embolism getting lodged, and then once it's lodged, platelets and other matter accumulate on it. The most common situation is that you have a DVT in your leg, a piece of clot breaks off, travels up the vena cava into the right side of the heart, and then lodges in the pulmonary artery or one of its smaller branches. So you can see the pulmonary artery has many branches. Platelets collect on the embolism, like I said, and trigger a release of substances that cause vasoconstriction. So not only are we blocking blood flow, but now we're vasoconstricting, decreasing the amount of blood flow that we could even possibly get to this area. And then the pulmonary vessels constrict, impairing gas exchange because oxygen isn't being exchanged, so therefore the patient becomes very hypoxemic. And we move deoxygenated blood into the arterial circulation. They develop pulmonary hypertension, which results in the increase of the right ventricle workload. The ventricle is working hard, and it can lead to right-sided ventricular failure. What are our risk factors? Anything that's a risk factor for a DVT puts you at risk for a PE. Prolonged immobility, surgery, especially laparoscopic, arrhythmias, trauma, central lines, obesity, age, a history of previous embolism, a state of hypercoagulability. Some people have blood disorders where their blood clots very readily. You learned about Fairchild's triad when you learned about DVT. The three components that put you susceptible to DVT are venous stasis, vessel injury, and hypercoagulability. Something else that can cause hypercoagulability would be dehydration. Some more risk factors: smoking, oral contraceptives. Doing both of those together puts you at 4 times the risk for a pulmonary embolism than doing one or the other. Pregnancy and postpartum, estrogen therapy, heart failure, stroke, patients with cancers, especially lung or prostate, and a sedentary lifestyle. So what are our clinical manifestations of PE? Well, classic feeling of impending doom. I'm going to die. They have such a high level of anxiety, and they just flat out tell you, I'm going to die. They'll have a sudden onset of dyspnea, and these symptoms that I'm talking about come with a massive PE. Pleuritic chest pain, sharp stabbing on inspiration. They're restless to go with that anxiety. They get tachypnic and tachycardic. They may have a dry cough or have some hemoptysis. And their breath sounds initially could be normal or have some crackles, but you're not going to hear horrible breath sounds with PE. That's the other thing is, your patient could be struggling to breathe, very anxious, and have normal breath sounds. They'll be diaphoretic from the increased workup breathing, have, of course, decreased O2 sats. That's why I put it so far down the list, because that's a given. Distended neck veins, just like in cardiac tamponade, they can have JVD. They'll develop an extra heart sound, either S3 or S4, which would indicate heart failure, a low-grade fever from the inflammatory process that's initiated. If they have a fat embolism, they might develop petechiae across their chest and axilla, syncope, and hypotension. Patients can die within 1 hour of onset of symptoms if they're not diagnosed, and or if they can't figure out what's wrong and don't start treating the patient. Our diagnostic tests, a VQ scan is used to be our gold standard, but not anymore. These ventilation perfusion scans take hours to perform, and they always came back indeterminate, and so therefore they stopped doing those as much. A chest x-ray won't really reveal smaller PEs. It might show a large PE, but a chest x-ray is not very reliable. They could do a pulmonary angiography and look at a direct visualization of the vessels. ABG is going to reveal hypoxemia and hypocapnia. EKG is going to show a tall peak P wave, some non-specific T wave changes, and a new right bundle branch block from the increased workload of the right ventricle and possible right ventricular failure. A D-dimer may be drawn, not always. Some facilities do, some facilities don't. And if it's positive, it reveals that there's a clotting taking place in the blood. And then the spiral CT, last but not least, is our gold standard now. Very accurate, very quick to perform and get the results. Our non-surgical management goals for treatment of a PE, we need to increase our gas exchange, improve our lung perfusion, reduce risk of further clot formation, and prevent complications. So increasing gas exchange, giving oxygen, mechanically ventilating the patient, improving lung perfusion, giving meds to dissolve the clot, reducing risk of further clot formation, putting the patient on heparin, and thinning out the blood, preventing complications that would be associated with a state of hypoxemia and the treatments that we need to administer. So our patient, like I said, is going to need oxygen. They may need to be ventilated. We need to monitor the patient closely for any changes in vital signs or signs of decreased perfusion. They need a lot of psychosocial support. It's very anxiety producing, being so short of breath. We're going to administer a heparin infusion as ordered. We want to maintain a therapeutic PTT, which would be 1.5 to 2.5 times the control of 25 to 35. So if the normal is 25 to 35, then a PTT of 70 would be considered therapeutic. Along with heparin comes monitoring for bleeding, reducing needle sticks, shaving with an electric shaver and not a safety shave, not a straight razor. We're going to monitor their platelet count. If it starts to drop, we need to suspect maybe they have a heparin-induced thrombocytopenia, and other testing has to be done. If they're a candidate for fibrinolytic, like DPA, we may administer that. And of course, with that comes the need for monitoring for increased bleeding. Surgical interventions. So what are our surgical interventions? Embolectomy, where we actually go into the operating room, open your chest, put you on a heart-lung machine, and manually remove the clots. A couple other places, we can go to the cath lab. There's a special catheter used called an angiojet that can break up clots and capture the clot pieces and pull them all out. But first, before we do any surgery or any invasive procedure, we need to reverse the effects of heparin. The reversal agent for heparin is protamine sulfate. The other thing that might happen if they're successful in treating the PE itself with medical management, but the patient is now at a higher risk for future PEs, is they might put an inferior vena cava filter in, like commonly known as a Greenfield filter, into catch and lyse clots. So patients are not passing clots from their legs up into the pulmonary vasculature. This is what it looks like. And basically, it's used for patients who would be at high risk for PE. Maybe they have some reason why they can't take any anticoagulation, or they just have a previous history of PE. So that's the information about pulmonary embolism. In class, we'll review a case study, and we will, I have a video to show you of surgical removal of a pulmonary embolism.